Sir. Bond.
Okay, Nadi. Okay.
Please start.
Yeah.
Sir, good evening. And we are very thankful for accepting the invitation to be our guest speaker for the next 15 lectures, sir. And we all know that your knowledge in oculoplasty has no boundaries. And we have seen you doing a gold plate implantation in Tirupati, sir, past, I think, 20 years back. And we still remember it, sir. And I think these lectures are going to be of immense helpful, not only for us, but for the students and also the oculoplasty surgeons all over India. Thank you, sir. Thank you once again for accepting our invitation. And I welcome you, sir, for the lecture.
Thank you, madam. Thank you, madam, for the opening remarks of this first of its kind oculoplasty online course by Subramaniam sir. So it's a honor to introduce Subramaniam sir to all of us. He actually doesn't need an introduction, but for the sake of postgraduates or the newcomers, Dr. Subramaniam sir is a professor emeritus of NTR University of Health Sciences. He is one of the senior most orbital surgeons in India. He did his fellowships in ophthalmic plastics at University of British Columbia, Vancouver, Canada, University of Wisconsin-Madison, USA. Sir has more than 40 years of teaching experience, including 20 years as HOD, ophthalmology. He started the Department of Ophthalmic Plastics and Orbital Services at Sarojini Devi Eye Hospital, Regional Eye Institute, Hyderabad, and also has the credit of starting the fellowship training program for ophthalmic plastics. He worked as a superintendent of Sarojini Devi Eye Hospital and Regional Institute, and he also gave his services as Director of Education, Sankar Foundation Eye Hospital, and later on became the chairman of Sankar Foundation Eye Hospital, Vizag. And he served as the academic director for Maharaja Institute of Medical Sciences, Nellimarla. Sir has more than 200 scientific papers, 100 invited guest lectures at various national, international, and state conferences. He also conducted several ICs and chaired sessions on oculoplastics. He authored a textbook on orbital diseases. He received more than 24 awards, including the Best Teacher Award, Ziegler International Fellowship Award, Sushruth Samman Award, the highest award from the Forum of Ophthalmic Teachers of India, Best Teacher Award by Acoin, and also Martin Memorial Award by Bangladesh Plastic Surgeon Society, Special Recognition Award from APOS, Dr. Vengal Rao Gold Medal, Raghavachar Gold Medal, Sonaina Award, and also Dr. Siva Reddy Endowment Award, and received the FICO honorary, and he was an examiner for postgraduates and FICO. Sir is also the former president of Oculoplastics Association of India, OPI, and also he is the past president of Andhra Pradesh Ophthalmic Society, and he is the president emeritus of Forum of Ophthalmic Teachers of India, chairman ARC committee of APOS, and he is also the member of Board of Education, NTR University of Health Sciences. Sir, thank you so much for accepting our invitation and starting this very, very unique course. And sometimes we ask for a master class of one lecture for 1 hour or 40 minutes. But this is very unique where you are yourself giving the lecture for the next 15 consecutive lectures. And I know it is not a small feat, sir. You have to devote a lot of time. And actually, sir has also upgraded his internet for this sake, especially. Thank you so much, sir, for taking the trouble and valuable time. Now I hand over the session to Subramaniam, sir, to take it over from here.
Good evening, Dr. Madhu and Dr. Sandhya. Thanks for the kind words of introduction. Now I would like to thank the scientific committee of the APOS and other members of the management committee for giving me an opportunity to share some of my knowledge with the postgraduates. And also I hope this will be of some use for the practicing ophthalmologists also. At the outset, I would like to tell the postgraduates that what I'm speaking is mostly of practical importance. It doesn't mean that this is A to Z of the subject. You have to read your textbooks. You have to prepare how you normally do. But the practical points that I'm giving should help you both in your theory, practice, as well as when you step out as a qualified ophthalmologist. So with this little introduction, I would like to start the lecture. Now, why should you know the anatomy and what is the normal thing? That's what we have to know to start with. Now, before we start the pathology of it, let's know what is the normal lid position. So, the upper lid covers 1/6 of cornea. That's what the textbooks say. Corneal diameter being 11 millimeters, we can say that it covers about 2 millimeters of the cornea in the straight gaze, and of course in whatever gaze it is, because the upper lid constantly follows the eyeball position in the vertical direction of movement, down gaze or up gaze. Whereas in the straight gaze, there's the primary position, the lower lid is just at the touches the 6 o'clock limbus. In other words, if the corneal diameter is 11 millimeters, since 2 millimeters is covered by the upper lid, the normal vertical height of the palpebral aperture is 9 millimeters. And as you all know, both the lids meet at corners, which we call it as canthus. So there are two canthi, the medial canthus and the lateral canthus. They are acute angled structures. They are not rounded off. That you have to do. Another thing that you have to know is that both the canthi are not at the same level. The lateral canthus is about 2 millimeters higher than the medial canthus. So why should you know the anatomy? If you prefer to do a surgery, now look at the rider who is there. The pillion rider is holding such a big baskets or some whatever it is, so that the driver is not able to see what is behind, and he can be prone for accidents. Similarly, the one who is behind the pillion rider is not able to see what is in front. So in case of an accident, he can't protect himself. There can't be any reflex actions. Similarly, why I'm saying this is, unless you know the anatomy absolutely clearly, you should not attempt doing a surgery. I would like to share an incident that has happened. One of a reputed ophthalmic surgeons wanted to do levator resection for a case of ptosis. He started the surgery, and once he saw the fat coming out after making the incision and doing the dissection, he was afraid that he was going into the orbit, and he abandoned the surgery and closed it and told me this so. But to be honest, he is in the correct place, because when you want to do a levator resection, in front of the levator muscle is the pre-aponeurotic pad of fat. So that's what he has seen. And if he has only retracted that, he would have found the LPS muscle. But since he is not sure of his anatomy, he scared and abandoned the surgery. Right. That is why I'm saying that when you want to do a surgery, the first thing that you should know is the anatomy, the relevant anatomy, you must be sure about it, that you should be able to visualize while doing the surgery. You must know the indications and the contraindications for the surgery before you attempt it. My surgery professor used to say, if you want to cut anything in the surgery, during surgery, cut. But you should know what you are cutting. That's what he used to say. So your anatomical knowledge and the dissection should be absolutely perfect. Then only you can become a good surgeon. So for that reason, anatomy of the eyelid is very, very important for all the subsequent lectures and surgeries that we will be discussing. What's normal position as we are discussing? Now, what you can see, this is the normal position where the upper lid is covering about 2 millimeters of the cornea. Lower lid is little at the lower part of the lower limbus. Actually, there's 0.5 millimeters of scleral show here. And if you look at the eyelashes turn a little down, come forwards and go up. This is how. But these few eyelashes here, you are seeing them going down. This is called lash ptosis, which is very much more evident in this lower picture. So the eyelid is in contact with the eyeball so that there is a capillary action between the two, and the tears that are secreted on the lateral side drain medially and have an access into the punctum, which is 1 millimeter in the inner surface of the lower lid, and similarly in the upper lid. So they drain like that. Now here, if you look at this patient, you can see that there is an entropion with the eyelid marge turned inside and the eyelashes rubbing against the conjunctiva and the cornea, that is called the secondary trichiasis. Whereas here in the lower picture, you can see that the eyelid has turned totally outside, that is ectropion, and seems to be of a longer duration with the dryness and semi-keratinization that is taking place in the lid. And you can see a lot of lash ptosis and a bit of ptosis also, all because of senile changes that are taking place simultaneously. Now let's start into what are the layers. Normally, some books say 2 layers, some books say 3 layers, but normally we decide practically for all practical purposes, we can divide the lid into 2 layers, an anterior lamella comprising of skin and orbicularis oculi muscle, and a posterior lamella comprising of orbital septum, pre-aponeurotic pad of fat, levator palpebrae superioris, Muller's muscle, tarsus, and palpebral conjunctiva. So these are the 2 lamella, an anterior lamella and the posterior lamella. Now, if you look into the surgical anatomy of the upper lid, here you have the skin. The skin is corrugated and you can see lots of small furrows in the upper lid. That's because you have an excess skin in the upper lid. Next to that is a subcutaneous connective tissue, and then to that you have the orbicularis oculi muscle. And next to the orbicularis oculi muscle, in the lower part, you have the tarsus, which is nothing but a combination of meibomian glands with connective tissue, which gives support and shape to the eyelids. There should be adequate tarsal support for the eyelid to have its shape. Inserted into the tarsus is the levator palpebrae superioris muscle. Some fibers from which gain access go in between the orbicularis oculi muscle and get inserted into the connective tissue and the skin to form the lid crease. Then behind that, you have the Mueller's muscle, which gets inserted onto the top of the tarsus. And posterior to the tarsus is the conjunctiva, palpebral conjunctiva. The palpebral conjunctiva is anchored or attached or glued to the tarsus, and it is almost impossible to separate the palpebral conjunctiva from the tarsus here. Whereas above the tarsus, it is loosely attached and can be very easily separated by a hydrodissection from the anteriorly lying Mueller's muscle. So it's very easy to separate the conjunctiva above the tarsus. The anterior lamella and the posterior lamella meet, and that junction is called the gray line. So attached to the and arising from the anterior surface of the levator palpebrae superioris is the thin membrane, the orbital septum, which is attached all round to the periosteum, both above and below. And behind the orbital septum and in front of the levator palpebrae superioris lies the pre-aponeurotic pad of fat. So these are the important steps of the anatomy of the upper lid. Coming to the lower lid, now one thing here is the LPS has attachments to the skin going through this. It has it gets inserted into the anterior surface of the tarsus in the lower 4 millimeters, so that there is a potential space between the levator palpebrae superioris and tarsus in the upper half, which is an important landmark in the levator resection surgery. Above the tarsus, you have upper arterial arcade, superior arterial arcade, and which lies between the LPS and the Mueller's muscle, and is an important anatomical landmark when you are doing the levator resection, when you want to spare the Mueller's muscle. The LPS is also inserted to the fornix, to the superior rectus, and to the periosteum on either side, passing through as the medial and lateral horns. So we'll come to the anatomy at a later stage. Coming to the lower lid, the anatomy is almost similar, that you have a skin, then connective tissue, orbicularis oculi, and then the tarsus, conjunctiva. And here, attached to the lower part of the tarsus is the inferior retractors, which are attached to the inferior rectus muscle. So that whenever we are doing an inferior rectus recession, it can pull the eyelid down because of this attachment and can cause lid retraction. These inferior retractors are almost similar to the levator palpebrae superioris, but since they are quite weak, the amount of action or the amount of pull that it causes on the lower lid is much lesser than the movement that or elevation that occurs due to the contraction of the levator palpebrae superioris. In other words, LPS being strong and having an accessory muscle, it pulls the lids by 15 to 20 millimeters, whereas the lower lid is pulled by the inferior retractors downwards from the upper to the lower position by about 8 to 10 millimeters. That is the reason why the width of the palpebral aperture varies in different directions of gauge. In the upper gauge, it's wider. In the lower gauge, it is narrower. In the mid gauge, it is medium size, is about 9 millimeters. The normal measurements are for the upper gaze in a normal person is about 15 millimeters, 12 to 15 millimeters. Straight gaze is 9 to 10 millimeters. And down gaze, it is about 4 to 5 millimeters is the normal width of the palpebral aperture in different directions of gaze. Now we'll go into the individual layers separately. The skin in the upper lid. The skin of the lid is the thinnest skin in anywhere in the body except or same as the prepucial skin in a male. This is the thinnest skin. So what does it mean? Whenever we are doing a skin grafting, we must look at a area of the donor where you can have a matching thin skin with the same structure. And there is excess skin in the upper lid in every person. That's why there is a lid crease, and you can, in this patient, you can see that there's actually a big lid fold, something like this, dermatochalasis that's happening there in an elderly patient. There's a big lid fold here. So this could be an excellent donor source for skin grafting whenever the need is small. Let's suppose about 10 millimeters by 15 millimeters of defect. I prefer to use the excess skin from the upper lid as the donor. In old age, the skin becomes much more relaxed, much more, and so it causes a big fold which can cover the lid margin and can become a big fold and can cause pseudotosis. That is called dermatochalasis. When we are talking of the lower lid, there is no excess skin in a younger patient. There is a little excess skin only in elderly patients, right? Hence, since there is no excess skin in the lower lid, when you are dealing with a case of trauma, you have to take every care to preserve the skin as far as possible while repairing the lid injuries. Otherwise, it can lead to a cicatricial ectropion. If there's a little irregular flap or skin, don't snip it off in the lower lid. It can cause ectropion. If it is there in the upper lid, a little zigzag irregular, and you won't be getting a good, beautiful scar, what you can do is probably you can snip it, since there is excess skin in the upper lid. But in the lower lid, you should be very, very careful. Try to preserve as much or more, almost all the skin in the lower lid while repairing the trauma. Okay. Lid shortening after trauma will lead to a lid lag on down gaze, as you see in this patient. So a badly done repair where the patient may look fairly good in straight gaze, but because of the scar, it can lead to a severe lid lag on down gaze and asymmetry, which is not acceptable for the patient cosmetically. Right. Here you can see after a vitreal loss, there is a severe scarring leading to lid shortening and lag of ophthalmos also. And sometimes the anterior lamellar shortening, there's a skin shortening, can lead to cicatricial ectropion also. So these are the things that you have to remember while dealing with the skin of the eyelid. When there is a vertical scar, you can do a Z-plasty. So where you make the incision, the vertical limb along the scar, then make 2 oblique incisions at 60 degrees. This is flap A, this is flap B. Now invert the flap A such that the apex comes down to this angle and flap B goes up, so that the vertical, since the flaps have come like this, the vertical height increases and the lid pull that is happening because of the vertical shortening gets obliterated and gets corrected. So this is a Z-plasty, which can be done for vertical scars. But when there is a big loss of skin, as you can see in cicatricial ectropy in case of burns, you can see that almost this lid is anchored or attached to the eyebrow. The lower lid is also, there is a lot of shortening in the case of vitriolus. So what we do is we make incisions about 2 to 3 millimeters and parallel to the lid margin, and then cut the scar and mobilize both and do a tarsography so that both the lids get one medial and one lateral tarsography so that the lid movement gets reduced. And this area is also gets expanded, the raw area gets expanded, and that area you fill it with a full thickness cutaneous graft. For such big gaps, or if we can say a surgical coloboma or anterior lamellar defect, you cannot fill it with a free cutaneous full thickness graft from the upper lid, excess skin that is there. So the best donor sites are post-auricular graft, pre-auricular graft, or supraclavicular skin graft. These are the full thickness cutaneous graft donor sites. And always, whenever you remember that, whenever we are doing a skin graft, the graft shrinks. How much? By around 20% for a full thickness graft and 30 to 35% for a partial thickness graft. The sites for the partial thickness graft are inner surface of the upper arm and inner surface of the thigh, where you have large areas without any hair, with hair-bearing areas. These are the best site for the grafts. So this is the patient pre and post op after for a case of cicatricial ectropy on right upper and lower lids because of a vitriolus, and another patient bilateral cicatricial ectropy treated with full thickness cutaneous grafts post-auricular in both the patients. Next to the skin is the orbicularis oculi muscle. This is the shutter. It closes the lids. And as you are aware, it is supplied by the facial nerve, and its paralysis of this orbicularis oculi leads to lag ophthalmos or incomplete closure of the eyelid. The orbicularis oculi can be divided into 4 parts, or simply we can say it as first to start with 2 parts, orbital and palpebral. Orbital is around the above the orbital margin, and the palpebral can be divided into 3 parts. Number 1, the F, that is the muscle of rayulon or marginal, near the margin of the eyelid. Next to that is the pre-tarsal, that is in front of the tarsus. Next is the preseptal. So the orbital part, preseptal, pre-tarsal, and muscle of rayulon are the orbicularis oculi at the lid margin. Orbicularis oculi has a very important role in the causation of involutional entropion and involutional ectropion. In both involutional entropion as well as involutional ectropion, some factors are common. That is, lid laxity is common and horizontal laxity is common. But why in some people there is ectropion? Why in some people there is entropion? This depends on this. If this pre-tarsal orbicularis oculi overrides onto the preseptal part, what is happening? E is going on to the D, it pulls the lid margin out. So it causes involutional ectropion. On the other hand, if the preseptal overrides onto the pre-tarsal part of the orbicularis oculi, what it does, it pushes the lid margin inside, and it leads to involutional entropion. So whether a patient develops involutional entropion or involutional ectropion depends on which part of the orbicularis overrides which part of the orbicularis. If the preseptal overrides the pretarsal, it causes entropion. If the pretarsal overrides onto the preseptal, it causes ectropion. So since these are senile changes, sometimes you can see patients with bilateral ptosis and involutional entropion in one side, involutional entropion on the other side. That also can happen. Then orbicularis oculi has another important condition. It is very, very important. That is the blepharospasm. The essential blepharospasm that happens is because of the constant contractures of the orbicularis oculi. Similarly, a constant contracture or spasm of the orbicularis oculi can lead to spastic entropion. So for all these things, orbicularis oculi is at the fault. And when it is loose, it causes and leads to lid laxity. And orbicularis oculi has also a very, very important function, that is in the lacrimal pump. The lacrimal pump mechanism is because of the orbicularis oculi. How does it happen? Let's look into it. The medial canthus divides into two, an anterior lamella and a posterior lamella. Our anterior part of the medial canthus gets inserted into the anterior lacrimal crest and the posterior into the posterior lacrimal crest. And in between the two is the sac, lacrimal sac. So here is the canaliculae, which runs through the lid, and both the canaliculi join to form the common canaliculae, which opens into the lacrimal sac. When the orbicularis oculi contracts, what is happening? It contracts both the canaliculi so that they become very narrow and they get blocked. So is the common canaliculae. So there is a pressure exerted over the lacrimal sac, and the fluid in the lacrimal sac is now only one way it can escape, that is through the nasolacrimal duct. So the fluid gets drained into the nasolacrimal duct. The tears get drained. When the orbicularis oculi relaxes, what's happening? The pressure over the sac and the canaliculi is released, all dilate. It causes a negative pressure, and these will suck the tears into the sac. And whenever the orbicularis again closes, the water, the tears that are in the sac get drained. So this lacrimal pump is because of the action of the orbicularis oculi. So remember that in a case of facial palsy, we can get the lids into great position. We can get the movements, but these movements will not be as good as that of a normal person. And hence, still they may be left with a bit of watering because of the imperfect functioning of the lacrimal pump. And this lacrimal pump is nothing but what we are doing is blinking about 18 to 20 times per minute. So that is the reason as per the lacrimal pump. And the functioning of blinking, or the purpose of blinking, is twofold. Number one is a lacrimal pump to drain the tears out. Number two, to spread the tears throughout the eyeball, conjunctiva, and cornea to wet the cornea, and so that the cornea is wet always and derives its oxygen from what is actually in the tear film, from which it can absorb this. Now, while evaluating for the orbicularis oculi and its functions, now here you can see that the patient has a mild ectropion, and on closure you can see that there is a huge lag of thalamus with a little bit of corneal exposure. For the lag of thalamus, you should not look straight. You should look from below. Here, because since the eyeball is curved, even if there is a 1 or 2 millimeters of the lag of thalamus is present, that will be obscured by the curved lid. So you have to look from below so that this 1 to 2 millimeters of the gap or lag of thalamus that you can see, you do not miss it. This is very important because in those conditions where you are going to do a ptosis, if you want to do, already if there is a lag of thalamus, your surgery may result much more lag of thalamus. You must be more careful and you have to counsel the patient on the consequences of lag of thalamus and you have to follow the patient. Then there are 2 important tests. Number 1 is called the pinch test. You hold the lid at the lid margin and pull it. Normally, you should not be able to pull it more than 6 millimeters. If you are able to pull it more than 6 millimeters, it means that it is lax. The second is snapback test. After you pull it, leave it. Normally, it goes and hits the eyeball with a thud. But if it doesn't go, goes very slowly, stops in between, it means that the lid is lax. The third is for the medial canthal tendon laxity. You hold the lid on the lateral side and pull it, and asking the patient to look straight in the primary gaze. If you are able to see the punctum coming up to the nasal limbus, it means the medial canthus is also lax, and the medial canthal tendon tightening is also required in that particular patient. So here you can see that this patient has a brow ptosis, then he has a dermatochalasis, almost obstructing the pupil. Here you can see a rounding of the border, that is because of the pre-septal orbicularis overriding onto the pretarsal, so that you can see that there's some small hump and then it is causing the secondary ichthyosis, and you can see that this patient has a cataract and has scoliosis, all the involutional changes, and with some amount of excess skin. This is a typical case of involutional entropia. After that, we will go to the orbital septum. Orbital septum is the boundary between lid or adnexal structures and orbital structure. What all is in front of the orbital septum is lids. What all behind it belongs to orbit. How to identify? Now, orbital septum may be, it arises, as I said, from the anterior surface of the levator palpebrae superioris and gets anchored all down to the periorbita, both in the upper lid as well as the lower lid. Sometimes it could be infiltrated with fat. Similarly, in case of congenital ptosis and occasionally in acquired ptosis also, there you can find some amount of muscle being infiltrated with fat. So, one more thing you have to remember is orbital septum need not be single layer. In other words, in some people, near about 15 to 20% in my experience, have 2 to 3 or 4 layers of orbital septum. So how to identify that? When once you have a doubt, you hold the tissue and pull it away from the orbital margin. If it's upper lid, pull it down. If it's the lower lid, pull it up. Orbital septum, you cannot pull it away because it is attached to the periorbita, to the bone. Whereas LPS can be pulled, levator palpebrae superioris, because it's not attached to the bone. It yields, whereas orbital septum does not yield. That is how practically we differentiate an orbital septum from a levator palpebrae superioris. Here you can see that I have cut the orbital septum. There is one more layer that I am cutting, and after second layer, you can see a big yellow flocule of fat. This is the pre-aponeurotic pad of fat. So there can be double and multiple layer orbital septum, that you must be sure. After you cut the orbital septum, next you have is the pre-aponeurotic pad of fat. How do you identify it from the other fatty infiltration of the tissue. This fat pad is very big in size. It's yellow in color, whereas others are less yellow in color. And one practical important thing is when you are seeing a case of lid trauma, when you are trying to repair it, if you find that there is an exposure of orbital septum and an orbital pre-aponeurotic pad of fat, it means that the septum has been torn. You try to gently retract the orbital pre-aponeurotic pad of fat, identify the levator palpebrae superioris, which is below that. And if there is an injury to the LPS, repair it there and then itself, and then repair the rest of the tissues. The presence of pre-aponeurotic pad of fat in a case of lid trauma is a red hair, is a sign that there may be injury to the LPS. Please, you have to explore it very, very well to identify the LPS. And if there is a damage, repair that to prevent a ptosis. LPS. LPS has 7 attachments. The most important is to the levator palpebrae superior, to the tarsus in the front, then one to the upper part of the tarsus. Few go in between the tarsus, orbicularis oculite onto the skin. Then you have some going to the posterior conjunctiva, then to the superior rectus, and then to the fornix and the lateral and medial horns to the bone. So there are 7 attachments of the LPS. It is the major elevator of the lid, and its action is about 15 to 18 millimeters. In case of ptosis, we always measure the action of the LPS, in which how we do is ask the patient to look down, keep your thumb over the eyebrow and press against the bone to nullify the action of the frontalis. Keep a scale and ask the patient to look up without moving his chin. How much the LPS has moved, you measure in front with the help of the scale. If the LPS action is 4 millimeters or less, we call it as poor. 8 millimeters or more is good. In between, that's 4.5 to 7.5 millimeters is fair. And more than 12 millimeters is very good. The normal action varies from 15 to 20 millimeters. And is the major elevator of the eyelid, as we have said. That is why the name given levator palpebrae superioris. Levator means the elevator. Palpebrum is the lid. Superior is upper one. So the major elevator of the upper lid. The name is given like that. It has a close association with the superior rectus because of the attachments. That's why whenever the patient looks up, the lid also goes to the same extent. If it doesn't happen, the lid obstructs the vision. So the lid should move, upper lid should move along with the eyeball. Then only the vision is not interfered with. So there is a close association between LPS and superior rectus muscle, and the upper lid moves along with the globe both in upward and downward gazes. What are histopathological changes of LPS in ptosis? Here is the histopathological changes that we have seen. This is a case of congenital ptosis, and you can see some amount of fatty infiltration, which is not very much. And you can see these are the normal muscle fibers. And what you are seeing is this is the fibrovascular tissue. So here is another case of congenital ptosis, where you can see mostly it is fibrovascular tissue with very less amount of normal fibrous tissue. In other words, in case of congenital ptosis, the muscle is replaced with fibrovascular tissue. As you are aware, the fibrous tissue neither contracts nor relaxes. Since the muscle is replaced with fibrous tissue, the total function or action of the LPS is reduced so that it cannot pull the lid to the normal extent, leading to the drooping or ptosis. Since there is fibrous tissue in the muscle, which cannot relax, when the patient looks down, this ptotic lid will not go down as much as the normal tissue, so that the width of the palpebral aperture on down gauge is more than that of the normal eye in the down case. Here in the lower part, what you are seeing is an acquired ptosis, where there is no fibrovascular tissue. What you are seeing that there's a lot of fatty disposition into the muscle, fatty infiltration into the muscle. And at the same time, what happens is, especially in involutional ptosis and all these cases, the attachment of the muscle to the levator is reduced, so that the pull is reduced. Its action is good, but since it doesn't have an anchorage, it leads to ptosis. And since there is no fibrosis in case of acquired ptosis, unlike in case of congenital ptosis, the lid droops down on down gauge and the width of the palpebral aperture becomes very narrow. Sometimes people complain that on down gaze, entire palpebral aperture can be closed, and patient finds it very difficult to do the near work and read unless he elevates the chin. The medial and lateral horns are these things. The medial horn divides and gets attached to the sac, and the laterals on the sac and above, whereas the lateral horn divides the lacrimal gland into palpebral part and the orbital part. The lateral horn of the levator divides the lacrimal gland into orbital, and this is the palpebral. Inside is the orbital, which has been divided by the lateral horn. And there are some natural folds on the face where you have to make the incisions so that the incisions are not clearly visible. They merge into the normal folds and scars. As far as possible, try to avoid a vertical incision on the lid, because it leads to a very bad scar. And we prefer to make incisions either along the eyebrow, below the eyebrow, the subciliary incisions, or along the crow's feet. These are the folds that are present on the lateral angle, or along the anterior lacrimal crest for the DCR and the DCT for the SAG, or a swinging lower lid incision where you cut a canthotomy, cantholysis, and make these incisions. So you have to know the places where you have to make incisions so that you can hide these scars and give a better cosmetic result. Similarly, you can approach the orbit through the conjunctiva or subcaruncular spaces to have a approach into the orbit without leaving any scar. The superior lid crease incisions are usually given for ptosis. This is the superior lid crease incision, which can be a small incision levator surgery or a normal full thickness incision levator surgery, or for orbitotomies, for facial palsies, where do a levator recession, or for a gold weight, or for the anterior orbitotomies, as you can see here, or even for a dermoid, that superior temporal dermoid, we can do a superior lid crease incision, push the dermoid into this incision and take it out so that there won't be any scar. Similarly, a lid crease incision can be given for a lateral orbitotomy, which is known as Harris lid crease incision. Mueller's muscle is the sympathetic system smooth muscle, which elevates the lid by about 2 millimeters. It's behind the levator palpebrae superioris, both being separated by the superior marginal arcade, not superior marginal, I don't say marginal, superior arcade of blood vessels, which is just above the tarsus, upper border of the tarsus, and lies between the Mueller's muscle and the LPS. As you can see here, this is the superior marginal of the blood vessels. This is the LPS in front, and here is the tarsus. And below this is the, behind this is the Mueller's muscle. Muellerectomy can be done for ptosis correction, where the minimal ptosis is improved with a phenylephrine test. And its palsy can lead to mild ptosis as in Horner syndrome, it's about 2 millimeters. And Mueller's muscle is also the reason for the lid retraction in thyroid-associated orbitopathy. Okay. So in case of Muellerectomy, what we do is we invert the lid and then infiltrate xylocaine subconjunctivally, xylocaine bupropion, so that you can, something like a hydrodissection of cataract, you can dissect the conjunctiva from the Mueller's, you make an incision, and then they make a small snip to see the blood vessels, and in that plane you can disinsert the Mueller's. This is the Mueller's from the tarsus, and in case of ptosis surgery, we cut this, and in case of lid retraction, we excise a part of it more on the lateral side, so that the Mueller's attachment to the tarsus is severe, and that takes care of the lid retraction. This is a patient of thyroid orbitopathy with, you can see there's a lid retraction and scleral exposure, as you can see, which has been treated with Muellerotomy both sides. Tarsus is composed of meibomian glands and connective tissue, and it provides the shape to the lid. That's why whenever we are doing the lid reconstruction, the most important thing we would like to emphasize is that it should have adequate tarsal support. What is adequate tarsal support in lid reconstruction? So the minimum amount of tarsus that is supposed to be present to provide adequate tarsal support is 4 millimeters in height and half the length of the eyelid. In other words, whenever there is a lid reconstruction, if the amount of surgical coloboma is less than 50%, there is no need to do the lid sharing procedures like Cutler-Beard's technique or a reverse Cutler-Beard technique and other things. You can get away with a canthotomy, cantholysis, direct suturing, or a Tenzel's procedure. In the lid margin repair, you first make your possible sutures through the gray line, or if the gray line is not visible, through the meibomian openings, which you can definitely see through the tarsus, and the tarsus gives beautiful support to pass these sutures through the meibomian openings and come out through the other eye, and make a knot and do the margin repair. The most serious carcinoma of the eyelids is a sebaceous cell carcinoma or meibomian cell carcinoma, which is more common in females, which is more common in the upper lids, since the upper lid has more number of meibomian glands than the lower lid. The cicatricial entropion in trachoma is due to the close adherence between the conjunctiva and the tarsus, so that when there is inflammation of the tarsus in trachoma and heals by cicatrization, the cicatrization also involves the tarsus and it leads to cicatricial entropion. So this is the scarring that I'm talking of. This scarring in trachoma leads to cicatricial entropion. Now this is how the patient is there with all the eyelashes rubbing against the cornea. And as you are aware, trachoma is a blinding disease. And thank God, India has been declared free of trachoma very recently. So whenever you need tarsal support is when the coloboma is very big and more than half the lid. So this to provide adequate tarsal support, we can have a hard palate graft, nasal septal graft, but nasal septum doesn't have the perfect mucosa, or ear cartilage graft, which doesn't have a mucosa. But I prefer a tarsal graft from the other lid. I'm sorry, because the upper lid has 4 times the normal requirement of the lid. So you can take a tarsal graft from the opposite, you can see the tarsal graft taken from the opposite upper lid, and which has been used in the reconstruction of the lid for a modified cutter wear technique. Conjunctiva, it provides a mucous membrane lining, which is very, very, very important for the health of the cornea. And the parts of the conjunctiva, as you are aware, are the marginal strip, then the palpebral conjunctiva, fornix, and the bulbar conjunctiva. The palpebral conjunctiva, as you are aware, as I have told you already, is closely attached to the tarsus, and it's almost impossible to separate it. The bulbar conjunctiva is loosely attached and can be easily separated from the Mueller's muscle just by injecting subconjunctivally the anesthetic drugs. Okay. And because of the closest attachment of the conjunctiva to the tarsus, in trachoma, the cicatrization of the conjunctiva also involves the cicatrization of the tarsus, and that leads to cicatricial entropia. Lower lid has inferior retractors, which is, for me, I consider as almost similar to the LPS, but it's weak. And its weakness is also one of the important factors for the development of involutional entropia. Since it is attached to the inferior rectus, this is inferior rectus attached to the inferior rectus. Whenever we do IR recession and pull the inferior rectus backwards, it pulls the lid down and leads to lower lid retraction. Lid crease importance that shows the LPS action. Presence of lid crease means there is some action of the LPS. And involutional ptosis, there will be multiple lid creases, and lid crease incisions, as I said already, are important to hide the surgical scars. And when we are making incision, we have to make sure that in a normal person, in Indian, we would like to create the lid crease in ptosis surgery. And whereas if I am dealing with an Asian eye, probably I should take most measures to prevent a lid crease in the Asian eyes. The canthal positions, as I said, the lateral canthus is higher than the medial canthus by 2 millimeters. If it is much more, it's called mongoloid tilt. If it's less, it's called anti-mongoloid tilt. Eyelashes are very important because it can, if it turns in, we call it as trichiasis. There's an extra layer coming from the tarsus. It is dystichiasis, which is congenital because of blepharitis. There could be madarosis. But most important thing, whenever you are seeing a tumor of the eyelids, loss of eyelashes in the lid margin point out towards malignancy. This happens because the tumor is involving the lid follicles. The eyelid follicles drop off. If you see this patient with basal cell carcinoma, here you can see that there are no eyelashes here. They are all lost. This indicates that apart from the ulceration, irregularity, and all these things, loss of eyelashes is also a very important point that shows that this can be a case of a malignant tumor. You should be very careful in dealing with that. Looking at the vascular supply of the eyelids are supplied in the upper lid mostly by the internal carotid artery and its branches, mostly the ophthalmic artery and its branches, and the lower lid by the external carotid artery, the facial artery, the angular artery, and their branches, forming marginal arcade and superior arcade. The marginal arcade is about 4 millimeters from the lid margin, and the upper arcade is at the upper border of the tarsus between the LPS and Mueller's muscle. So that's what you are able to see here. This is the lower marginal arcade. the superior margin arcade, that is this one, and this is the superior arcade between the Muller's muscle and the levator, which is behind this aponeurotic pad of fat. And these branch, there are lots of communications between these two, and the lids are very highly vascular. That's very good for the reconstruction. And one important thing is, even if your patient comes with a lid that is cut off, a part is cut off and brings it to you immediately, just you can wash it, rinse it with saline and betadine, and you can use it to suture it. And usually it survives, right? So the lids are very highly vascular, and that's why the lid grafts, everything, usually they survive very, very well. That same sitting, we have to say that patients who are on blood thinners should definitely stop that whenever we are doing surgery on the eyelids. So that is also one thing that we have to remember. Coming to the lymphatic drainage of the eyelids, the upper lid drains to the pre-auricular lymph nodes, and the lateral part of the upper and lower also go to the pre-auricular lymph nodes, whereas the medial and the lower lid will drain to the submandibular lymph nodes. This is the classical teaching, but there is an article which said that they have injected radio and did a scintillography, and they found that among 28 patients, there were no lymph nodes in 3 people. And most of them, more than 20 of them, they have only pre-auricular lymph nodes, in which the tracer has gone. So that is one thing, but don't write that in the exams. When you see a patient of a lid tumor, your hand should automatically go to palpate the pre-auricular lymph nodes and submandibular lymph nodes and lymph nodes. That is very, very important. Thank you all for listening to me for this 1 hour. And if you have any doubts, anything, probably I'll be more than happy to try to clear them off. Thank you.
Shyam, did we get any questions in the chat board?
No questions. So if there are no questions, thanks a lot. And I
Sir,
hope
thank you
it
very much,
gives you
sir.
some practical knowledge to the surgical anatomy of the eyelid. Thank you so much.
Thank you so much, sir. It was very clear and lucid. I think, again, we'll meet next Tuesday with introduction to ptosis and classification of ptosis.
Yes.
Yeah, so
Sir.
PGs can prepare in advance so
Yeah.
that you can follow, sir, better for the next class.
Sir,
Thank you, sir. Madam,
Thank you.
please.
I don't have any words to say, sir, but it was extraordinary, exemplary. And you reminded me of my PG days, sir. Thank you very much, sir. I'll never forget this lecture.
Thank
The
you, sir.
importance, the clinical applications, and the anatomy, really wonderful, sir. Thank you very much, sir. Looking forward for the next lecture, sir.
Thank you so much, Sanjay. Thank you so much.
Good night, sir.
Good
Bye.
night.
Good night.